everyone. My name is Sabahat Ahmed. I'm a junior doctor at the Royal Surrey County Hospital in the UK. It's a pleasure to be here. Thank you for having me. I'm going to be presenting an audit I've conducted with my consultant and registrar on the management of bone health in breast cancer patients on aromatase inhibitors. So just starting off with a bit of background, aromatase inhibitors form a key part of adjuvant endocrine treatment for postmenopausal women with hormone receptor positive breast cancer. So they prolong disease-free survival, reduce the risk of distant metastases, and reduce the risk of contralateral breast cancers. However, because they cause accelerated reduction in bone density, they're also associated with osteoporosis and increased risk of fractures. In fact, a study done published in the New England Journal of Medicine found that the relative risk between postmenopausal women with detectable estradiol levels as opposed to postmenopausal women with undetectable estradiol levels for risk of vertebral and hip fractures was 2.5. So because there's an increased risk of reduced bone mineral density with aromatase inhibitors, current guidelines suggest to complete a DEXA scan. So here's the algorithm of modified to fit our trust for patients who've been started on aromatase inhibitors. So all patients should be started on an aromatase inhibitor with knowledge of what their bone mineral density is at baseline. So their DEXA scan should be completed within 6 months. Following on from this, they should have their bone health managed according to their T-score. If their T-scores are above -1 or showing normal bone mineral density, then they should be given lifestyle advice. If their T-scores indicate osteopenia, they should be given calcium and vitamin D supplementation. And if their T-scores indicate osteoporosis, then they should be given bisphosphonates. So for the first cycle of our audit, we collected quite a bit of information on patient demographics, the final histology of their tumor after surgery, the aromatase inhibitor that was started, when it was commenced, side effects, and compliance. Regarding the DEXA scan, we collected data on if the DEXA scan was performed, when it was performed, where it was performed, what the results were, and what the management plan was following after this. We collected results from a range of different areas, mostly clinical letters, but when that data was missing, we sometimes phoned GPs and sometimes the patients themselves to make sure none had fallen through the net. And because in our trust, patients are sent to many different hospitals to get their DEXA scans completed, each hospital uploads their results onto different electronic systems, and we had to search through at least 6 electronic systems just to find out what those results were, and I'll come on to that in a bit. So following our first cycle, we presented our results at a local departmental meeting attended by breast surgery consultants, juniors, and breast care nurses. And this was followed up by an educational intervention. So we presented what the guidelines are, the rationale behind those guidelines, and the importance of adhering to those guidelines. We then did our second cycle where we collected data on the next 20 patients after our intervention who were prescribed an aromatase inhibitor and found out whether or not there was a positive effect on our education intervention. So just starting off with some results from the first cycle. The average age of the patients studied was 67, and there are a range of different histological findings. The most common grade of tumor removed was grade 2, most common cancer type was invasive ductal carcinoma, and there was an equal distribution of the sizes of cancers removed, ranging from 1 to 175 millimeters. 12% of patients who had been started on an aromatase inhibitor presented to hospital with a fracture since it had been commenced. 27%, almost a third, reported side effects, including joint pain, and 10% stopped taking the aromatase inhibitor because of side effects, specifically joint pain, and all concerns regarding the effects on their bone health, such as osteoporosis. So this slide shows the compliance to the guidelines, that is, whether or not the patients had a DEXA scan and the timing. So in red and blue here, we have the patients who had their DEXA scan. So over 80% of patients did have a baseline DEXA scan. In fact, only 66.1% had it within 6 months, which is the recommended time frame. In blue, we have the patients who had it after 6 months, and in purple, unfortunately, the patients who were missed or didn't have a DEXA scan. Interestingly, everyone who didn't have a DEXA scan was also started on adjuvant bisphosphonate therapy as part of their cancer treatment, which I'll come on to in a bit. So, as I mentioned before, because all of our patients are sent to different trusts to get their DEXA scan completed, we also looked at whether or not it's the trust that we send them to that's causing a delay. So, as you can see here, Hospital A takes the majority of patients who have their DEXA scan. And because they take the majority of patients, that might explain the large variation it takes in the time taken for a patient's DEXA scan to be completed. So purple is patients who have had their DEXA scan after 6 months, not ideal, and patients who've had their DEXA scan for a good time is in blue and red. So even though Hospital A takes the majority of patients, it's more hospitals D and B who have a disproportionately lower percentage of patients compared to A, but have completed their DEXA scans within good time. So moving on to what the DEXA scans actually showed for these patients. Over half of patients were found to have osteoporosis, which emphasizes the importance of adhering to these guidelines. These patients are already at high risk, being postmenopausal and female. About a third were found to have osteopenia, and less than 20% had normal bone mineral density. So once we figured out what those results were, we looked at whether or not, once these patients were identified to have osteopenia or osteoporosis, were they managed correctly. In fact, 76.2% of patients found to have osteoporosis were commenced on bisphosphonates, but unfortunately 23.8%, even though they were identified to have osteoporosis, didn't receive any medical treatment. This could be for a number of reasons. First of all, it takes a while for scan results to come back. Every time that there's a delay in scans to come back, there's a risk on every clinic appointment for clinicians to forget that there's something to chase up and something to be acted on. Second, this is a part of treatment where patients phase out of for breast surgeons having the responsibility of their care and for oncologists to kind of take over. And it becomes unclear sometimes whose responsibility it is to act on the results of the DEXA scan. And that might indicate why these patients have been missed. Similarly, the majority of patients found to have osteopenia were treated with calcium and vitamin D supplementation as per treatment guidelines, but unfortunately 16.6% didn't receive any medical treatment. So this slide just shows a summary of the outcomes of patients who had their DEXA scan according to the T-score. So in summary, the majority of patients did have their DEXA scan, and most of them were actually found to have osteoporosis. But there was still some variation in the treatment patients received, even once they were identified to have osteopenia or osteoporosis. So following these results, we figured there is room for improvement, I'm sure you'd all agree. We delivered these results to our local departmental meeting, and this was followed up by an educational intervention, a refresher session on the guidelines, and talking about the rationale and why this is so important to adhere to. We then completed a second cycle looking at the next 20 patients who were prescribed an aromatase inhibitor and if there had been an improvement. There has been an overall 10% improvement, which is encouraging, but still some area to continue to improve. So further suggestions. Following our first cycle, we've identified 3 main areas that our trust needs to improve on. First of all, the proportion of patients who have their baseline DEXA scan, those who have it within good time, and standardization of treatment once results are available. We were hoping the educational session that we provided addressed all these 3 categories. So starting off with optimizing the proportion of patients who have their baseline DEXA scan, we could, I appreciate that everyone here is from a different healthcare system and different trust, and this is specific to the trust that I completed the audit at. But I'm hoping that by presenting a few of these suggestions, it might give you a few ideas to see for improvements that you can make within your own departments going back for things that are often overlooked for patients, such as bone density on patients on their aromatase inhibitors. So we've just moved on to an online system in our trust. So one of the ideas that was presented by one of the other juniors was to create a pop-up reminder whenever an aromatase inhibitor is prescribed, to to remind the clinician prescribing it to request a DEXA scan at the same time. Also, there's more of a culture now to empower patients for them to take their health into their own hands. So we could tell patients, expect a letter from the hospital with the date of your DEXA scan. And if you don't get this letter, then please contact us on this number and we'll find out why this hasn't been done. And that just helps with patients who have a risk of slipping through the net. Finally, improving patients who have their DEXA scan within good time. So we identified 3 main areas that could be a delay. First of all, standardizing the team requesting the scan. Like I mentioned before, phase of treatment is at a time when breast surgeons kind of tail off and oncologists kind of pick up the lead on treating these patients. So, and when we were collecting data, we noticed DEXA scans were requested by a range of different specialities, sometimes even rheumatologists or GPs. So by standardizing the team that request the scan, we also standardize whose responsibility is to chase up the results and act on them. Second, standardizing the trust that performs the scan. We've already seen that there was quite a lot of variation in the number of, in the proportion of patients who have their baseline DEXA scan in good time by trust. So by streamlining all patients to a specific trust or equally distributing the patients across all 4 trusts, we might improve on the time in which a DEXA scan is completed for the patient. And finally, standardizing where results are uploaded to. Because there are 4 different trusts we send our patients to, we have 4 different electronic systems results are uploaded to. And because there's a delay between results being transferred between the 2 trusts, that also creates a delay in the treatment these patients have. And often in the adjuvant phase, patients have appointments every few weeks. And in the meantime, every day they're taking their aromatase inhibitor without any protection if they need it. So by standardizing where the results are uploaded to, we also improve the efficiency at which we can act on these results. Finally, there's a question to ask on whether or not patients who need to be started on adjuvant bisphosphonate treatment as part of their cancer treatment anyway need to have a DEXA scan. Part of the reason we do a DEXA scan is to find out if patients need bisphosphonates. If they're taking it to reduce the risk of bone recurrence, and it also covers for any osteoporosis they have, then that's beneficial. So do they need a DEXA scan? I'd argue yes, because it's also the follow-up DEXA scan that tells us how quickly a patient's bone density is reducing. If a patient has an accelerated reduction in bone density over 2 years, then that might affect oncologists' decisions in the duration of aromatase inhibitor therapy that we choose to give patients, which we know can range from 5 to 10 years. Finally, standardization of treatment. So we already provided an educational intervention for patients, for the clinicians in the department to remind them of the guidelines available and how to treat osteopenia and osteoporosis. Not something I think is on the forefront of the minds of most breast surgeons. But we could also provide quick reference guides for clinicians in clinic rooms through posters for them to refer to during clinics when they get the DEXA scan results back. So just to conclude, although the majority of patients had their baseline DEXA scan on commencement of aromatase inhibitor, 66.1 didn't have it within 6 months, which has improved by 10% following our educational intervention. Of those found to have a DEXA scan, the majority were found to have osteoporosis, which emphasizes the importance of identifying these patients and treating them correctly. And there was some variation in the management of bone health noted. We'd further like to suggest standardization of the location the DEXA scans completed, discussions and agreements, or at least more further guidelines working with the oncology team to figure out whether or not patients on adjuvant bisphosphonate treatment should have a DEXA scan, and empowering patients themselves to be proactive in the management of their own bone health, so they feel less out of control when it comes to the side effects of aromatase inhibitors, and in this way, they're more likely to be compliant with the medication. References. Thank you very much.